It is my pleasure and honor this night to have one of the pillars of pediatric nephrology in Arab world, Professor Bassam Saeed from Syria. Always we are happy to deal with this man because he had a very nice attitude toward his colleagues, either younger or older from him. So the Professor Bassam Saeed is the consultant pediatric transplant nephrologist at private clinic in Damascus from January 2019 up to date. He is honorary fellow of the Royal College of Physicians, Edinburgh, founder and president of Farah Association. I'm going to highlight a few points about Farah because I like this association very much. He is a past president of the Middle East Society of Organ Transplantation, and he's a member of the Scientific Council of Pediatric Nephrology, a subspecialty of the Arab Board of the Health Specialization Council, member of Declaration of Istanbul, member of ISN Middle East Region Board, member of the honorary committees of advanced international training courses, founding member of the World Academy of Medical, Biomedical and Ethical Sciences, and this is very important. And when we speak about ethics, we are speaking a man of ethics, Professor Bassam, member of Declaration of Istanbul Custodian Group, a lot of committees in the Arab, international, and everywhere, regional representative of the Middle East and Africa region in the KDIGO from November. He is a consultant pediatric nephrologist at Al Jahra Hospital in Kuwait up to 2018. And he was the president of Middle East Society of Organ Transplantation up to 2018. Head of pediatric nephrology in Damascus and director of pediatric nephrology. So this is the very prestigious and honorary positions that Professor Bassam Saeed had. He is the editorial member, board member and reviewer in many regional and international journals, more than 47 publications, a number of reviews, textbook chapters, and these, as I mentioned in the last meeting about transplantation, he has a very nice writings about transplantation in Syria and in Oregon. And regarding Farah Association, this is a very nice association, very political, very ethical, and it is non-profit, voluntary charity organization, duly registered as society affiliated to the Ministry of Social Affairs in Syria with effect since 2013. The mission is to provide help and serve the needs of kids suffering from chronic kidney disease and their families, as well as to promote support for kidney donation and transplantation for children in Syria. Very important mission. This is the profile of Professor Bassam Saeed in Scopus, and this is I like that in 2020 Farah Association, this is the affiliation. So he considered Farah as one of the best and the most important stop in his life, and I think it is very valuable because it serves the community. A lot of publications and citations, and the most important publication, I didn't consider this in the previous meeting, long-term outcome of steroid-resistant nephrosis syndrome in children, and this is Professor Bassam Saeed here, and this is in Journal of American Society of Nephrology, and this article includes a lot of data from BODONET consortium about steroid resistance, predictors, outcome, the issue of genetics and everything. So I advocate all my colleagues and the professors to review and read this article. He is also a man, and I like one of his posts a couple of days ago about the love and the respect. So all love and respect to Professor Bassam and his family. And this is Hatshepsut. Today we have one of the Arab and Egyptian stars in pediatric nephrology, Professor Fatina Fadel, as a moderator of this meeting, and she is also well known in nephrology, dialysis, and moreover, transplantation in Abu Rish Hospital. Always, I'm happy to meet Professor Fatina Fadel, and this is one of the very nice crews in Aswan. Also, Scopus profile of Professor Fatina, and she has a lot of publications in the field of transplantation, nephrosis syndrome, and others. I'm sure this night that Professor Bassam Saeed will enrich the Egyptian, Arab, and International Library in Nephrology about his updates in hypertension in pediatric age. So I'll be happy to hear from Professor Bassam. And before his presentation, I would like to declare that all ESNT, CME virtual meetings are not sharing any sponsor from companies, so they are volunteer, non-profit, like Farah, it is non-profit educational activity. Thank you very much, and I leave the mic to Professor Fatina Fadel just to welcome Professor Bassam before his start to share his slides. Dr.
Welcome, yes, welcome, Professor Bassam. It's my honor always to.
Okay, Professor Fatina.
Can you hear me now?
Yes, please.
Yeah, it's my pleasure to introduce dear colleague, Professor Bassam. Very happy to be with you and to share with you such.
Okay, so it is
Yes.
our pleasure, Professor Bassam. It seems that the net is not good with Professor Fatina. And would you please share your slides? And until you share your slide, I would like to welcome all my professors and colleagues, especially from Jordan, Professor Riyad Saeed, and from Saudi, Professor Faisal Shaheen, and all my colleagues and professors from Egypt, Professor Saad Khamis, Dr. Tariq Tantawi, and all colleagues attending this Zoom meeting. Professor Bassam, the mic is to you, and please share your slides.
Thank you very much. My slide is there. Isn't shared?
It's not shared yet. Please.
Okay. First of all, I would like to thank you very much, Professor Hussein, for this very kind and nice introduction. I do not deserve all this. In fact, thank you very much. This reflects your honesty and everything. And thanks again for Professor Fatina Fadel, my good friend, for everything and for moderating this session. I hope that we will all have some updated information about pediatric hypertension, especially last few years we have lots of update in this topic. Let me start by the outline of this session. We'll first talk about the fourth report on hypertension in children, which was issued in 2004, and then we will identify high-risk population requiring more aggressive screening, and then we will talk about prevalence of hypertension in children, and most importantly, we will go through the new American Academy of Pediatric Childhood Hypertension guidelines, which were issued in 2017, like 3 years ago. But please let me start with this case. Very, very short case. For a reason, I want to present this case in one slide only. It is about a 13-year-old boy with blood pressure of 142/65. The blood pressure was taken for general checkup visit before enrollment in a sport program. The blood pressure has been repeated in the doctor's office. It was again 135/70 and again 147/68. It seems that the systolic blood pressure is high. Now, every doctor, I mean about pediatricians, when they receive such a case, the first question should come to mind is, does this boy have hypertension? What is the most likely diagnosis? And how extensive a workup is required? And this is the message. The message is that when we see a hypertensive child, we first of all should ask ourselves, is it really hypertension? It could be white coat hypertension. So this kind of question probably are not present when it's about an adult patient coming for hypertension. Then the second question, what is most likely diagnosis? Because quite often hypertension is a marker of some other problem, unlike what we see in adulthood. And how extensive a workup is required. it is not, most of the time, especially in young children, it is not essential hypertension. Therefore, we need to investigate this hypertension and go for workup to see what is the cause behind this hypertension. From this case, short case, we understand how pediatricians are approaching children with high blood pressure. Let's go to hypertension in adults in the United States. These are certain facts. Hypertension affects approximately 1 in 3 US adults. Something around 70 million people in the States are having hypertension. The total cost of hypertension treatment in the US, $70 billion. And hypertension is estimated to cause 13% of all deaths. That's why screening of hypertension in adults is justified. This is very normal. I mean, when it comes to pediatrics, things are a bit different. Hypertension is a marker of other problems that we need to look for. And hypertension during childhood predicts the presence of hypertension in adulthood. Cardiovascular event might occur after several decades after hypertension. That's the reason why hypertension in childhood is just the beginning of long history of hypertension during adulthood, with all the cardiovascular disease event and etc., etc., etc. So tracking studies for childhood hypertension resulted in the solid conclusion that childhood hypertension is a predictor of adulthood hypertension. Therefore, I don't know how much of the patients having hypertension in adulthood, they were also hypertensive during their childhood. So childhood hypertension is a predictor of adulthood hypertension. First of all, we need to identify childhood hypertension. That's why we have standards for blood pressure in children. These standards are statistical definition derived from a database of blood pressure taken in normal children. Let me start by the second task force report, which was in 1987. That report, it was based on 9 studies performed in the UK and the United States, involving more than 70,000 children. That's the reason why we call it statistical definition. So the childhood blood pressure standards are statistical definition based on 9 studies from the United States and United Kingdom, depending on age, gender-specific percentile curve were generated at that time. 9 years later, the second task force data had new reference blood pressure standards were issued based on height percentile. So they have added the height in addition to age and gender. So from 1996, blood pressure is depending, the definition of blood pressure will be depending upon not only age and gender, but also the height. And we'll see why later. In 2004, the very famous fourth report of childhood hypertension was issued. It includes a new classification according to severity of hypertension. So now from 2004, we start talking about severity, elevated blood pressure, then stage 1 hypertension, then stage 2 hypertension, and they have added recommendations for evaluation of children with elevated blood pressure. So definition of hypertension, first of all, what's the normal blood pressure? Normal blood pressure, when the systolic and diastolic blood pressure less than 90th centile for age and gender and height. While hypertension, when the average systolic and diastolic is greater than or equal to 95th centile for sex, age, and height on 3 or more occasions. And this is very important to know that we need to take the blood pressure for at least 3 times, 3 different occasions, not to take the blood pressure 3 consecutive times in the same occasion, 3 different occasions. If it was always exceeding, equal to, or exceeding 95th centile, then we say this is hypertension. This table in front of you will summarize what we need to see in this normative table. We call it normative table. As you can see here, we have tables for boys and we have tables for girls. This table is for boys. We see here the age per year and blood pressure percentile and the height percentile. So when we take the height of a child, we need to see this height corresponding to which percentile of height. And then again, we have here certain columns for systolic and certain columns for diastolic. So definition of hypertension, pre-hypertension, when the average systolic or diastolic blood pressure levels are greater than or equal to 90th centile, but less than 95th centile. So between 90th and 95th, it was before called the pre-hypertension. Now, starting from the 2017, we call it elevated blood pressure. But anyway, we'll come to it later on. But when it comes to adolescents with hypertension, we don't talk anymore about centile, we talk about fixed figures. We see here that for adolescents, whenever the blood pressure levels greater than or equal to 120/80 millimeter mercury should be considered pre-hypertensive. So we'll come to it also later on. Very important term in pediatric, it is white coat hypertension. White coat hypertension, this is a patient with blood pressure level above 95th centile in a physician office or clinic or any clinical setting who is normotensive outside the clinical setting. So in the clinic, he's hypertensive. Outside the clinic, he is not, he is normotensive. This is, we call it white coat hypertension because, you know, children, usually they are anxious, they are afraid for very comprehensive reasons. So ambulatory blood pressure monitoring is usually required to make the diagnosis, especially when we think of this white coat hypertension. And we'll come to it also later on about this ambulatory blood pressure monitoring. This is the classification of hypertension in children and adolescents. We see here the normal blood pressure is when the systolic or diastolic percentile below 90th. When it is below 90th, blood pressure is normal. Those kids, when they are normal, they are normal. We check during scheduled physical examination, that's it. And therapeutic lifestyle, if the patient was obese, of course, we have to encourage healthy diet. But the pre-hypertension, as I said before, when the blood pressure levels are above 90th to below 95th centile, or if blood pressure exceeds 120/80, even if below 90th. So whenever it is above 120 or 80, it is pre-hypertension, even if it is below the 90th centile. And from 90th centile up to below 95th centile. Those patients with pre-hypertension, we advise them to recheck in 6 months. And we always advise them for weight management. We introduce physical activity, especially for those who are overweight or obese, and diet management. We also will come to it later. But no pharmacologic therapy here at this level of hypertension, unless if there is some compelling indications such as chronic kidney disease, diabetes, heart failure, or left ventricular hypertrophy. If they are there, then we think of starting pharmacologic therapy. Now, stage 1 hypertension, when the blood pressure levels are above the 95th centile, equal or above the 95th centile to the 99th plus 5 millimeter mercury. Here, we check the blood pressure in one. As I said before, no hypertension when the systolic or diastolic blood pressure are below 90th centile. Pre-hypertension, this is when the blood pressure exceeding 90th centile to below 95th centile. Here we have to recheck the blood pressure in 6 months. And therapeutic lifestyle changes are important whenever the patient is overweight or obese, in addition to introduce physical activity and diet management. No pharmacological therapy indicated unless if there is some compelling indication like CKD, diabetes, heart failure, or left ventricular hypertrophy. Now, stage 1 hypertension, when the blood pressure levels are at 95th centile to 99th plus 5. Here we have to recheck the blood pressure in 1 or 2 weeks or sooner, depending upon the patient. If the patient is symptomatic, we have to recheck sooner until we confirm that the patient is really hypertensive by in three different occasions. The management here almost the same like pre-hypertension. Therapeutic lifestyle changes like weight management and introducing physical activity and diet management. The pharmacological therapy is not indicated unless there is compelling indication. With regard to stage 2 hypertension, whenever the blood pressure exceeds 99 plus 5, here the blood pressure the patient should be referred to a source of care within 1 week or immediately, depending on the patient clinical condition. The weight management is indicated plus the overweight, plus the physical activity and diet management, depending upon the whether the patient is overweight or obesity. But regarding pharmacological therapy, of course, here we have to start pharmacological therapy because this is sometimes it could be life-threatening hypertension. Definition of hypertension, as you see in this table, we need to see different parameters. First of all, the gender of the patient, like here, this table is for boys. And if we take an example, for example, a boy who is 2 years old, his height is at 25th centile, then we have to look at this different blood pressure centile for his age and height centile, and this is for diastolic. What is the most important point here is to look at the 95th centile. 95th centile because at 95th or above, it means that the patient is hypertensive. So for this patient who is 2 years old, boy 2 years old, at 25th centile for height, if the systolic blood pressure equal or above 104 and diastolic equal to or above 60, then the patient is considered hypertension stage 1. What about stage 2? Stage 2, if it exceeds 99 plus 5, the 99 is 111 for the systolic and 68 for the diastolic. If we add 5, so if the patient having a systolic blood pressure exceeding 116 for this patient, then we say that this is stage 2 hypertension or diastolic. Not necessarily both should be elevated, one or two. And if the diastolic exceeding 73, which means 99 plus 5. So this is an example of how to confirm the diagnosis of hypertension. Now, what are the conditions under which children younger than 3 years should have blood pressure measured? Because according to recommendation, all kids above the age of 3 years, their blood pressure should be measured at least annually. But sometimes for certain patients, we check blood pressure for children who are younger than 3 years. For example, prematurity, if the patient had history of prematurity below 32 weeks or small for gestational age or very low birth weight or nursery younger than 3 years should have blood pressure measured. First of all, those who have history of prematurity, severe prematurity below 32 weeks or history of small for gestational age or very low birth weight or history of nursery ICU staying or history of umbilical artery line, and patient with congenital heart disease, recurrent UTI, hematuria or proteinuria, children with non-renal disease or urologic malformations, children with family history of congenital renal disease, children with solid organ transplant, children with malignancy or bone marrow transplant, children treated with drugs known to raise blood pressure, children with systemic illnesses associated with hypertension like neurofibromatosis, tuberous sclerosis, sickle cell disease, and elevated intracranial pressure. Can you hear me now? Okay, so this slide summarizes what I was talking. So this is the condition: prematurity, heart problem, kidney problem, malignancy, drugs, and other. Now let us move to how to measure blood pressure. First of all, we have to be sure to use the right sized cuff. Right sized cuff requires from us to see the arm length and the arm width. The arm length, it is the distance between acromion and olecranon. We have to measure it, and the arm width should be taken, should be taken from the mid space between acromion and olecranon, because the cuff bladder width should be equal to 40% of arm circumference. Or other references, they say that cuff width should be equal to 2/3 of the arm length. So we can't use the same cuff for all pediatric patients. Pediatric patients are different, too much different in size. And this is the way how to measure the distance from the acromion to olecranon. Now, moving to treatment of hypertension. First of all, diet, as I said before, diet and exercise. Diet, it is very common to ask patients not to take salt or to reduce the sodium intake. In fact, reduction in sodium intake lower blood pressure if the patient or the child was having salt-sensitive hypertension. Otherwise, the patient will not respond to reduction in sodium intake. DASH diet appears to be safe and effective. What we mean by DASH? DASH means diet approach to stop hypertension. So DASH diet, it was ranked best diet overall for 8 years in a row by United States News and World Report. DASH diet is also a good diet for diabetes, heart health, and healthy eating, originally designed to lower blood pressure. But now the indication for DASH diet exceeds this initial indication to lower blood pressure. Now it is very effective for weight loss, for lowering cholesterol, and managing or preventive diabetes. What is DASH? It is very simple. Eat more fruits, vegetables, and low-fat dairy foods. Cut back on foods that are high in saturated and cholesterol and trans fats. This is a very interesting study published maybe 15 years ago to look at the effect of a short-term diet and exercise intervention on metabolic syndrome in overweight children. Small number of children, 16 children only, they were placed on high fiber and low fat diet for 2 weeks, along with daily aerobic exercise. In a matter of 2 weeks, they have noticed that systolic blood pressure has significantly decreased from 130 to 117. And the diastolic blood pressure also has decreased from 74 to 67. So as you can see, 2 weeks only, it was enough to reduce blood pressure, but it's not always easy to tell people eat fruit, vegetable, don't eat fat, and the way changing habits is very difficult, but we have to insist on it because this is the way forward to manage hypertension, especially in obese and overweight children. What about using pharmacologic therapy in children? First of all, we have to know that in children, the long-term consequences of untreated hypertension are unknown. We don't know what are the consequences if the high blood pressure left untreated. Additionally, no data are available on the long-term effects of antihypertensive drugs on growth and development. Therefore, a definite indication for initiating pharmacologic therapy should be ascertained before a drug is prescribed. Now, what we should learn from the 2017 American Academy of Pediatrics guidelines for screening and management of high blood pressure in children and adolescents. It was published and issued on 22nd of August 2017, like 3 years ago. Now, what is this 2017 American Academy of Pediatrics Clinical Practice Guidelines? They are actually an update to the 2004 fourth report on the diagnosis, evaluation, and treatment of high blood pressure in children and adolescents. Lots of new data that forced the American Academy of Pediatrics to update the fourth report. Now, why it is important to look at the 2017 American Academy of Pediatric Clinical Practice Guidelines? First of all, because they are developed with a strict evidence-based approach, number one. Number two, they are aligned as much as possible with a new hypertension guidelines for adults. Three, we had last 10 years a good number of new data that led to notable modification of the 2004 recommendation and the generation of entirely new recommendation, and we'll come to it later. Now, one of the difference between 2017 American Academy of Pediatric Guidelines and the 2004 report is that the new one excluded overweight and obese children. They are not included in the normal or normative table that was generated by these guidelines. This resulted in blood pressure values that were on average 2 to 3 millimeter mercury lower than those in 2004 fourth report. So when we talk about pediatric patients, very clearly we are talking about so different patients in terms of size, in terms of arm length, cuff size, and morbid, and also the causes of hypertension. The causes of a small child is different from a child who is adolescent, for example. So we are dealing here with a mix of so unhomogeneous patients, if I can say. Now, what are the standards for assessing and measuring and monitoring blood pressure in children? The right arm is preferred in general, unless if there is some problem. Sitting position is the best position we measure blood pressure. Crying and eating can happen because we are dealing with children. Crying and eating can influence blood pressure measurement. We have to be patient. We have to wait until the patient is calm and retake the blood pressure. Any movement can affect the accuracy of automated blood pressure monitors exactly. Auscultated movement will not change a lot the blood pressure level, but if we are taking blood pressure by dynamap or oscillometric or automated blood pressure monitors, movement can affect a lot. We have to take it again and again until the blood pressure was taken while the patient was not moving. And the first reading of automated monitor should be disregarded as a rule of thumb. Now, what is the prevalence of hypertension in children? This is a very good question, which is not easy to answer it, because first of all, let me say about what are the information on the prevalence of hypertension in children. It is, in fact, largely derived from data typically is based on a single blood pressure measurement session. Unfortunately, most of these studies on prevalence of hypertension, it was based on single blood pressure measurement. And based on this, high blood pressure is consistently greater in boys than in girls. In boys, it was from 15 to 19%, which is quite high, almost 20%. 20% means 1 out of each 5 children, they are hypertensive. It's not, I mean, we will talk about it later, because it was based on single blood pressure measurement. In girls, 7 to 12%. The prevalence, it seemed that it was higher among adolescents than among younger children. But now, what is important, with repeated blood pressure measurement, the prevalence of confirmed blood pressure was lower. So the prevalence is much lower than we thought previously. When we measure blood pressure repeatedly, the actual prevalence of hypertension in children and adolescents is 3.5. This is the number that we have to remember. 3.5% of children, they are hypertensive. 3.5 is not a little. Means out of each 30 children, 1 of them is hypertensive. So if we go to any school, in any school, if you go to the room, if you see 50 children, maybe 1 or 2 of them, they are hypertensive. So the prevalence of persistently elevated blood pressure, which means blood pressure values from 90s to 94s, or between 120/80 and 130/80 in adolescents, is also 2.2 to 3.5. So we have 3.5% hypertensive and 2.2 to 3.5 pre-hypertensive. If we combine both, it be something around 6 to 7% of children, they are either pre-hypertensive or hypertensive. Higher rate among children and adolescents who have overweight and obesity. The probability increase if the patient is overweight. Now, it's very important to know that only 15% of children who have high blood pressure are diagnosed. Only 15%. The remaining 85%, they are hypertensive and nobody knows about. So we are failing, if I can say, to diagnose hypertension for the majority of hypertensive children. Why we are failing to make the diagnosis? There are several reasons. First of all, blood pressure in children is a function of age, sex, and height percentile. It's complex. It's not easy to know exactly what is the percentile for each patient according to his age, sex, and height percentile, because we have to go back all the time to this normative table. And what is normal for one child may be considered hypertensive in another child of the same age. So if you take two children, same age, but different in height, so the same blood pressure could be normal for one and hypertensive for the other. This makes it also more difficult. Last point, clinicians usually cannot remember normal blood pressure. Of course, thousands of figures. Nobody can remember this normal. We have to refer always to this normative table. All this together make it difficult to diagnose hypertension for all patients, for all children who are really hypertensive. Now let's go to see the summary of the key action statement for screening and management of high blood pressure and adolescents according to the 2017 American Academy of Pediatrics guidelines for hypertension. First of all, the replacement of the term pre-hypertension with the term elevated blood pressure. We don't say now pre-hypertension, we call it elevated blood pressure. But if the patient exceeds 95th centile, we call it hypertension. If it is 90th to 95th, we call it elevated blood pressure. See, these figures now is we have to remember it always for children who are less than 13 years, because always children who are above 13 years they have fixed figures. But here we below 13 years of age, we have to look at the percentile. So after the age of 13, no percentile, only figures. So children below 13 years of age, normal blood pressure, if it was below 90th centile, elevated blood pressure from the 90th up to 95th centile, or 120 over 80 at any age. At any age, if it is above 120 over 80, it is elevated blood pressure. Now, stage 1 hypertension, equal or above 95th centile to 95th centile plus 12. It is no longer like before, like 2004 forced task. It was 95th up to 99th plus 5. No, here from 95th to 95th plus 12. Or from 130 over 80 to 139 over 89, whichever is lower. Now, stage 2 hypertension, all figures exceeding 95th centile plus 12, or exceeding equal or exceeding 140 over 90 millimeter mercury, whichever is lower. Now, for children who are aged above 13 years of age, normal blood pressure is less than 120 for systolic and less than 80 for diastolic. Now, elevated blood pressure for adolescents above age 13, whenever the systolic is from 120 up to 129, but diastolic should remain below 80. Now, stage 1 hypertension from 130 over 80 to 139 over 89. Stage 2 hypertension over equal or above 140 over 90. So this is the table. It is very, it looks complicated, but it's not complicated in fact. As you can see here, they have added the 95th centile plus 12 millimeter. And this is the 95th, and this is 90th, and this is 50th. And here they put the height in inch and centimeter, okay? Now, they have generated also the American Academy of Pediatrics, this simplified blood pressure table, because sometimes it looks complicated and we need something simple. So they have simplified a table for initial blood pressure screening. It is about the 90th centile, because above the 90th centile, we are talking about elevated blood pressure. So this is a very simple table. We have seen here, for example, boys and girls, systolic, diastolic, diastolic for both boys and girls. And here, age by years. If I have a patient, for example, 4-year-old boy, 4-year-old, 102, this is equal to the 90th centile. If the patient has systolic blood pressure equal to 102 or above, it means that the patient requires further investigation, starting with repeat blood pressure. So first of all, if the patient having these figures, which are corresponding to 90th centile, it means that the patient requires further evaluation. Further evaluation means the patient might be hypertension. That's why the first step is to repeat blood pressure measurement. If it was confirmed in 3 different occasions, then we have to do the further investigation to know whether it is secondary or not. Now, blood pressure should be measured annually in children and adolescents age 3 or above year of old, okay? So starting from the age of 3 years, blood pressure should be measured for all children, at least annually. But if blood pressure, if the children have certain problem like obesity, history of medications known to increase blood pressure, or having renal disease, or having history of aortic arch coarctation, or are diabetic, then the blood pressure not only annually, once annually, but at every healthcare encounter above 3. So I will say it again: if children are above 3 years of age and they have one of these problems, blood pressure should be measured at each healthcare encounter, not once annually. Now, how to diagnose and confirm hypertension? Trained healthcare professional in the office setting should make a diagnosis of hypertension if a child or adolescent has, first of all, auscultatory confirmed blood pressure reading. So auscultatory, not by automated blood pressure machine. Second, if blood pressure exceeding, equal, or above the 95th centile. Third, at 3 different visits. So 3 visits, all of them equal to or above 95th, and by auscultatory blood pressure measuring. So at that time, we can diagnose hypertension. So hypertension can never be established with one single measurement, or even 2. We need at least 3 measurements. Oscillometric device like Dynamap, which are very common, we use it very frequently in hospital, especially in the ICUs and in the NICU, nursery ICU. It can be used, of course, for blood pressure screening. But if the oscillometric device tells us that blood pressure was elevated, so here we suspect high blood pressure, then the confirmation should be by auscultation. So auscultation here is necessary to confirm the diagnosis of hypertension. Now, moving to ambulatory blood pressure monitoring. It should be performed for confirmation of hypertension in children with office blood pressure measurement in whenever the blood pressure remain elevated for more than 1 year, or for a patient who was diagnosed with stage 1 hypertension over 3 clinic visits. It is preferable to go for ambulatory blood pressure monitoring, especially when we have certain problems we will go through in a few minutes. I think we all are familiar with this ambulatory blood pressure monitoring. This is a device, and this is a cuff. It measures blood pressure over 24 hours. This device, we have to pay attention that it should be validated. We have to read and see and make sure that it was validated. Second, we have to choose the correct cuff size. Okay. Three, the third point, right and left arm and lower extremity blood pressure should be obtained to rule out coarctation of the aorta before putting this device and measuring blood pressure over 24 hours. So we have to exclude the possibility of or coarctation of the aorta. And we usually use the non-dominant arm unless there is a large difference in size between the left arm and the right arm. At that time, we apply to the arm with the higher blood pressure. We always choose the arm with higher blood pressure if there is significant difference between the two arms. Now, this ambulatory blood pressure monitoring device, usually we are programming it on our laptop or computer. We can program it as we want according to our desire. For example, but we have to know that the readings should be taken every 15 to 20 minutes during the day and every 20 to 30 minutes during the night. Okay, during the night, we measure it less frequently than during the day. And the patient, while doing this ambulatory blood pressure monitoring, the patient or the family or the parents, they have to record time of medications, activity, and sleep in order to, this will allow us when it comes to interpretation of the blood pressure over these 24 hours, sometimes we correlate and we establish some link between high blood pressure to activity or low blood pressure during sleep, etc., etc. A physician who is familiar with pediatric ambulatory blood pressure monitoring should interpret the results. Not anyone can interpret the results. Someone who is familiar with. We require at least one reading per hour, and a full day we need at least 40 blood pressure measurement during a day. It's far better than just measuring blood pressure once or twice in our office, because this device will measure blood pressure over so many different conditions: rest, sleeping, activity, walking, etc., eating, after medication, before medication, etc., etc. So, and then when it comes to interpretation of the data, we have to calculate the mean blood pressure and the blood pressure load. What we mean by blood pressure load, the percent of reading above threshold. Usually it is the 95th centile to know what is the load of hypertensive readings. And dipping, also we have to calculate the dipping. Dipping means the percent of decline in blood pressure from wake to sleep, because usually physiologically, blood pressure declines during the night. When we sleep, our blood pressure fell down. And we will talk about it later also. Then we interpret with pediatric ambulatory blood pressure monitoring normal data. There are specific normal data by sex and height for this device. Now, there are certain high-risk conditions that require routine performance of ambulatory blood pressure monitoring. It should be strongly considered, this ambulatory blood pressure monitoring, whenever the children we are caring having high-risk conditions, because this ambulatory blood pressure monitoring will determine the hypertension severity, and if we detect some abnormal circadian blood pressure pattern, then this may indicate increased risk for target organ damage. So will tell us more, the ambulatory blood pressure monitoring, about the severity and about the abnormal circadian pattern and the prognosis also, and the possibility of having target organ damage. This is an example. You see this graph, the blood pressure during the night, how it falls a little bit, more than 10%. You see, this is during the day, evening, and this is night, and this is the morning next day. We started here at 3 p.m. and we finish at 3 p.m. next day. So 24-hour ambulatory blood pressure monitoring, daytime and nighttime, 24 hours. The blood pressure load, as I said, this is the percent of values above cutoff. Sometimes cutoff, most of the time it is the 95th centile, but sometimes we need to know the 95th plus 12 or 90th centile, depends. And we look at the dipping, how much the patient declined his blood pressure from daytime to nighttime. So nocturnal blood pressure drop, or what we call it dipping, as you see here in this figure, very, very beautifully, the patient dropped his blood pressure. Again, in the morning, raised his blood pressure. So usually nocturnal decrease in systolic and diastolic exceeds 10%. Exceed 10%. If the systolic was 120 during the daytime, at least during the nighttime should be 110. The mean dipping in healthy children, 13% for the systolic and 23% for diastolic. So diastolic declined almost twice as the systolic. So dipping present in 100% of normotensive. So normal people, 100% of them, they are dipping their blood pressure during the sleep. And more than 90% of patients with mild essential hypertension. If we are talking about essential hypertension, those who are having essential hypertension, they are also dipping in 90% of cases. But non-dipping, if the patient was non-dipping, the blood pressure remains the same day and night, then this may indicate secondary hypertension. And this is one of the benefits of doing blood pressure monitoring, because this may tell us that pay attention, maybe this patient is having secondary hypertension, you have to look for the reason. Non-dipping predict also cardiovascular mortality. Look here, we have, in this study, we have 4 categories of patients, those who are normotensive here, and behind they are hypertensive. Even among normotensive, if we do it, the ambulatory blood pressure monitoring, see, even if among normotensive patients, those who are non-dipper, they have higher cardiovascular mortality. But if you go and look for those who are hypertensive, the difference is even higher. The relative risk is so high for those who are non-dipping. So non-dippers have higher mortality risk compared to dipper. Now, this is a percentile of ambulatory blood pressure monitoring according to height. These tables are specific for ambulatory blood pressure monitoring. As you can see here, we have the systolic and diastolic. We have the daytime and nighttime, and we have the height for boys, and there is other table for girls. So it tells us what is the 90th centile, 95th centile for the day and for the night. This is very important to know about this, because at the end of the day, when we interpret the results, we need to know what is the mean pressure during the day and mean pressure during the night. Now, there are high-risk conditions for which ambulatory blood pressure may be useful. So we cannot say that ambulatory blood pressure monitoring should be done for all patients with hypertension. No, I cannot say this, and the guidelines are not saying this. But there are certain high-risk conditions. What are these high-risk conditions where ambulatory blood pressure may be useful? First of all, secondary hypertension. Why? Because when we see severe ambulatory or nocturnal hypertension, this indicates higher likelihood of secondary hypertension. Now, regarding patients with chronic kidney disease or structural renal abnormalities, it's very useful here to monitor their blood pressure by ambulatory blood pressure monitoring. Why? Because quite often the patient in our office is normotensive, but when we do ambulatory blood pressure monitoring, we detect some, we call it masked hypertension or nocturnal hypertension. So if we treat them, then this will lead to better control of hypertension, and therefore this could delay the progression of renal disease. Now, diabetic patients also, because diabetic patients, if we evaluate their blood pressure by ambulatory blood pressure monitoring, this can detect some high blood pressure, and better blood pressure control delays the development of microalbuminuria and the development of diabetic nephropathy. Obesity also, we usually look for white coat hypertension and masked hypertension. both of them, white coat hypertension and mask hypertension, are very common among obese patients. And the same can be said also for obstructive sleep apnea syndrome. For patients with sleep apnea syndrome, we have to evaluate the non-dipping, because those patients usually they don't dip during the night, and next day morning they have accentuated morning blood pressure surge. This cannot be seen if you measure blood pressure only in your office. So we need 24-hour monitoring. Solid organ transplant, of course, we may detect some masked hypertension or nocturnal hypertension. And if we manage this hypertension, which is masked, then this will lead to better control of blood pressure and we protect the graft. Now, repaired coarctation of the aorta, we need to evaluate for sustained hypertension and masked hypertension. And there are certain genetic syndrome associated with hypertension like neurofibromatosis, Turner syndrome, Williams syndrome, coarctation of the aorta. All these genetic syndrome, usually the patient, they do have some increased arterial stiffness. And this increased arterial stiffness may only be, the blood pressure may only be high when during activity. So if you do ambulatory blood pressure monitoring and the patient is doing some exercise or so activity, then we notice that during this activity, blood pressure is high. So this is very useful to do ambulatory blood pressure monitoring for those patients with this rare genetic syndrome. And patient treated for hypertension, we need to do it because we need to confirm that the patient is responding to therapy and he is becoming normotensive over 24 hours, not only during the visit to the doctor. So we need to confirm 24-hour blood pressure control. And also, when the patient is born prematurely, we have to look for non-dipping, because the premature children who were born prematurely, they are known to develop non-dipping hypertension. So if we want to combine both methods of measuring blood pressure, whether it is office blood pressure measurement or 24-hour blood pressure measurement, we have 4 scenarios. Maybe both are normal, then the patient is confirmed to be normotensive. But sometimes the patient in the clinic is having elevated blood pressure, but when we do 24-hour monitoring, we see that the patient is normotensive. So this is, we call it white coat hypertension. White coat hypertension, the patient is having high blood pressure in the office, but normal in 24-hour measurement. But the opposite is when the patient is having normal blood pressure in the office, but 24-hour measurement is elevated. This we call it masked hypertension, and we'll talk about this later on. Now, sustained hypertension, the blood pressure is high in both ways. Now, masked hypertension, the prevalence of masked hypertension is 10 to 20%. The patient with masked hypertension were more often obese and were more often twice as likely to have a parental history of hypertension, because hypertension, masked hypertension, is an independent predictor of sustained hypertension. Maybe the patient now is having masked hypertension. I couldn't detect it unless if I do ambulatory blood pressure monitoring, but later on, after 1 year or 2 years, the patient will become more evidently having hypertension during the office visit, etc. So masked hypertension is independent predictor of sustained hypertension. Now, when we suspect white coat hypertension, we should undergo ambulatory blood pressure monitoring. As I said, diagnosis of white coat hypertension is based on the presence of mean systolic and diastolic blood pressure below 95th centile, and systolic diastolic blood pressure load is less than 25. So the patient is not hypertensive. But look what we say here. We look at the mean systolic and mean diastolic over 24 hours, not on single measurement. The mean will be below 95th, both of them, systolic and diastolic. And the systolic blood pressure and diastolic blood pressure load is less than 25%. Why we are talking about load? Because when we do blood pressure monitoring over 24 hours, we take 40, 50, 60, depend on how you programmed your device. 60 readings, sometimes 10 out of these 60 readings were above 95th centile, but this 10 out of 60, it may be less than 20%. So we call it the load. The load below 25, so we don't take it into consideration. Okay, so white coat hypertension is defined as blood pressure exceeding 95th in the office, but less than 95th percentile outside the office. The load is defined as the percentage of valid ambulatory blood pressure monitoring above a set threshold, which is usually 95th percentile for age, sex, and height. It is very important to know that half of children who are evaluated for elevated office blood pressure have white coat hypertension. That's why it's the only way to confirm whether the patient was really having hypertension or he's having white coat hypertension is to do ambulatory blood pressure monitoring. What about home blood pressure monitoring? Home blood pressure monitoring, we can't rely much on it and should not be used to diagnose hypertension, mass hypertension, or white coat hypertension, but may be a useful adjunct to office and ambulatory blood pressure measurement after hypertension has been diagnosed. Children after the age of 6 years do not require extensive evaluation, but patients who are below 6 years, they do require extensive evaluation to look for the specific cause of their hypertension. But after the age of 6, they don't do, unless, especially if they do have positive family history of hypertension. If there is family history, finished, okay. So, or the patient is overweight or obese, or there is no history of or physical exam findings suggestive of a secondary cause of hypertension. So we are reluctant, in fact, to go for complicated investigation for children who are diagnosed with hypertension after the age of 6 years. Now, ambulatory blood pressure monitoring is also used to assess treatment effectiveness in children with hypertension, especially when clinic and or home blood pressure measurement indicate insufficient blood pressure response to treatment. So it is very good also to monitor. It's not only for the diagnosis, but only for the assessing the treatment effectiveness. Now, what about patients with CKD? CKD patients, chronic kidney disease and hypertension should be treated to lower 24-hour mean arterial pressure below 50th centile. So we have to treat them aggressively. So mean blood pressure should decrease below the 50th centile. You remember mean arterial pressure, how to measure it? It is 1/3 of the systolic plus 2/3 of the diastolic. Now, patients with CKD and hypertension and proteinuria should be treated with ACE inhibitor or ARB, or sometimes both. Now, in children with severe hypertension and life-threatening symptom, immediate treatment with short-acting antihypertensive medication should be initiated, and blood pressure should be reduced by no more than 25%. We shouldn't rush to decrease blood pressure because sometimes the patient may collapse. Because if the patient was hypertensive, especially for a long time, it's not safe to lower blood pressure for more than 25% over 8 hours. Now, what are the findings suggestive of secondary cause of hypertension? As I said before, perinatal history is very important to look at. Whenever we evaluate a child with high blood pressure, we have to take his perinatal history. We have to look at his nutritional history and also physical activity, psychosocial history, family history, and of course, physical examination. Now, what are the physical examination findings suggestive of a secondary cause of hypertension? Now, let me start with this, the vital signs. First of all, if the patient was tachycardic, we have to rule out hyperthyroidism, pheochromocytoma, and neuroblastoma. If the patient is having decreased lower extremity pulses or drop in blood pressure from upper to lower extremities, then we have to evaluate him for coarctation of the aorta. Now, if we look at the eyes, if the patient is having proptosis, we have to rule out hyperthyroidism. If the patient is having some retinal changes, we have to consider severe hypertension, or this patient most likely he has some secondary hypertension. Now, regarding the ear, nose, throat, if the patient is having adenotonsillar hypertrophy, then we have to consider this diagnosis, which is disordered bleeding. the breathing is not normal because of this obstruction, because of this adenotonsillar hypertrophy. And if there is a history of snoring, we have to consider sleep apnea. Now, if the patient is having growth retardation, first of all, chronic kidney disease. If the patient on the opposite is obese, then we have to rule out Cushing syndrome. If the patient is having truncal obesity, we have to think of insulin resistance syndrome. Now, the head and neck, depending on the facies. If elfin facies, we have to consider Williams syndrome, moon facies, Cushing syndrome, thyromegaly, goiter, hyperthyroidism, web neck, we have to consider syndrome. Sorry if the slide is busy. If the patient was having pallor and flushing, we have to think of pheochromocytoma. If the patient is having acne, hirsutism, striae, we have to consider Cushing syndrome, anabolic steroid abuse, neurofibromatosis for café au lait spots. If the patient having adenoma sebacum, we have to consider tuberous sclerosis. If the patient is having malar rash, we have to consider systemic lupus erythematosus. If the patient is having acanthosis nigricans, the patient might be diabetic. Now, if the patient is pale, we have to consider renal disease. If the patient is having some chest pain, palpitation, exertional dyspnea or widely spaced nipples, we have to consider heart disease. If the patient is having widely spaced nipples, we have to consider Turner syndrome. If the patient is having heart murmur, coarctation of the aorta, if is patient having friction rub, patient may have systemic lupus erythematosus or pericarditis or collagen vascular disease. If the patient is having apical heave, the patient might have left ventricular hypertrophy. Now, in the abdomen, if the patient is having abdominal mass, we have to consider Wilms tumor, neuroblastoma, pheochromocytoma. If the patient is having epigastric or flank bruit, then the patient may have renal artery stenosis. If the patient is having palpable kidneys, then we have to consider polycystic kidney disease or hydronephrosis or multicystic dysplastic kidney. Now, if the patient is having ambiguous or ambiguous genitalia, the patient may have congenital adrenal hyperplasia. If the patient is having urinary tract infection or VUR or hematuria, edema, fatigue, abdominal trauma, then we have to consider renal disease. If the patient is having joint swelling, we consider systemic lupus or collagen vascular disease. If the patient is having muscle weakness, we consider hyperaldosteronism or Liddle syndrome. If the patient is having hypokalemia, headache, dizziness, we consider reninoma. If the patient is having muscle weakness, we consider monogenic hypertension, especially Liddle syndrome, and mineral corticoid excess. Okay, now these are the causes of hypertension depending on age group. Neonate, first of all, we think of coarctation of the aorta and renal artery thromboembolism due to the catheterization of the umbilical artery, and renal artery stenosis, congenital renal abnormalities. So they are also big diagnosis and very risky diagnosis: coarctation and renal artery thromboembolism, renal artery stenosis, congenital renal abnormalities. Now, infancy to 6 years, here we start talking about renal parenchymal disease. Coarctation of the aorta still is considered. Renal artery stenosis is still considered. Above the age of 6 years, we don't talk anymore about coarctation of the aorta, but renal artery stenosis still could be there. But first of all, renal parenchymal disease. So renal parenchymal disease is the first option after the age of neonate. In the age of neonate, it is not considered. But here we have to pay attention to this. Patient above 6 years, we start considering essential hypertension. So essential hypertension can be in children as small as 6 years of age. If we go for adolescents, the first diagnosis is essential hypertension and renal parenchymal disease. So renal parenchymal disease accounting for 75% of causes. Renovascular 10%, aortic coarctation 8%, and endocrine and other 7%. Some doctors, they start by looking at the different endocrinal disease. In fact, renal parenchymal disease is accounting for 3/4 of causes. And essential hypertension, some people, they don't know that essential hypertension does exist in children. But of course, not very small children. If you go to neonate or infant, it does not exist. But starting from the age of 6 years, it starts to be there. When you reach adolescence, it almost 50 or 60% of causes. But in adult, of course, it can be up to 90% of causes. Now, what are the investigations that we have to ask for when we diagnose hypertension? We have 3 phases. Phase 1 is for everyone: CBC, urinalysis, biochemistry, lipid profile, chest radiography, ECG, echocardiography, and renal ultrasound and Doppler. Renal ultrasound. And phase 2, we have to do MCUG to rule out VUR. We have to do DMSA or scintigraphy, DTPA, and we have to do CT, MRI, or MR angio, and vanillyl mandelic acid, renin, aldosterone. So this is not for everyone. This is based on clinical setting and the whole clinical setting. If we suspect anything, if we suspect by ultrasound there is, for example, hydronephrosis, we go for MCUG and DIMSA. Now this is a phase 3. It's even more complicated. We go for angiography, differential renin vein renin sampling, renal vein renin sampling, and MIBG, which is meta-iodobenzyl guanidine. This is functional imaging, especially for neuroblastoma. And we look for catecholamines, especially when we think of pheochromocytoma. Now, what about echocardiography? It is recommended that echocardiography be performed to assess cardiac target organ damage at the time of consideration of pharmacologic treatment. So according to this new guidelines of the American Academy of Pediatrics, echocardiography should be done when we consider to treat the patient with drugs. In children diagnosed with hypertension, the treatment goal should be reduction in systolic diastolic blood pressure to below 90s. So our target when we treat patients with hypertension, our target is to reduce systolic and diastolic, both, to below 90th centile or below 120/80 in adolescents. At the time of diagnosis of elevated blood pressure or hypertension in a child, clinicians should provide advice on the DASH diet. As I said before, we know about the DASH diet now, and recommend moderate to vigorous physical activity, at least 3 to 5 days per week, each time 30 to 60 minutes per session to help reduce blood pressure. This is part and very effective part of our therapy, DASH diet and physical activity. Pharmacology comes later. Now, if hypertensive children who have failed lifestyle, but really failed, but sometimes the patient is not willing to do it, this is very difficult and challenging situation. But anyway, we have to manage. We have to decrease his blood pressure. So in hypertensive children who have failed lifestyle modification, particularly those who have left ventricular hypertrophy, symptomatic hypertension, stage 2 hypertension without a clearly modifiable factor like obesity, then at that time, clinician should initiate pharmacologic treatment with ACE inhibitor, ARBs, long-acting calcium channel blocker, and thiazide diuretic. We'll come to treatment later on also. Now, if we look at the European Society of Hypertension guidelines of 2016, what are the indications to start pharmacologic therapy? First of all, if the patient was having high normal, which means elevated blood pressure, which means from 90th to up to 95th centile, non-pharmacological treatment, lifestyle changes. If the patient having life-threatening hypertension, of course, we have to go straight for pharmacological treatment. But the question is here, when the patient is having hypertension, means above 95th centile, but not life-threatening hypertension, and having one or more of the following: symptomatic hypertension, secondary hypertension, organ damage, diabetes, then we have to go for pharmacological treatment, like life-threatening medication. But if the patient doesn't have any of those causes, he's not symptomatic, he doesn't have secondary, and he doesn't have organ damage, then again, we have to treat him by lifestyle and diet and introducing exercise. Now, what are the indications for pharmacological treatment based on the 2017 American Academy of Pediatrics Clinical Practice Guideline. Sustained hypertension, despite a trial of lifestyle modification, this is an indication to start pharmacological therapy. If the patient is still hypertensive despite lifestyle modification, or if the patient is having symptomatic hypertension. If the patient is symptomatic, we don't wait until the patient undergo a lifestyle modification. And if the patient is having chronic kidney disease or diabetes, this is an indication also to start pharmacological therapy. And this is one of the difference between the American Academy of Pediatric guideline and the force report of 2004. Because here in 2004, it was not included, the chronic kidney disease. The fourth indication is all patients with stage 2 hypertension without a clearly modifiable factor. I mean, if the patient was obese, then we have to start him with lifestyle modification. If it failed, then again, we have to consider pharmacological therapy. Now, what is the blood pressure target? When we treat patients with hypertension, our target for all hypertensive children, including diabetes, is to achieve blood pressure below the 90th percentile for age 6 and high, or below 120/80. While in the past, during the, according to force report, it was our blood pressure target was below 95th. But now our target is below 90th, not 95th. Why? Because when the patient is having target organ damage, when the blood pressure, when the blood pressure is between the 90th and 95th, which means elevated blood pressure or pre-hypertension, at that time, target organ damage can appear even at this level of blood pressure, which is, we call it now, elevated blood pressure. And that's the reason why during this 2017, the American Academy of Pediatrics, they have lowered the blood pressure target to be below 90th centile, not below 95th centile. Now, they have considered patient with chronic kidney disease, and they recommended that our target should be 24-hour mean arterial pressure below the 50th percentile by ambulatory blood pressure monitoring. It was not mentioned before. Before, in the force report, it was below 90th centile, but now we are talking about ambulatory blood pressure monitoring, and the mean arterial pressure should be below 50th. This is one important difference between the two guidelines. Now, what about the choice of drug for patients with chronic kidney disease and diabetes? The first agent is ACE inhibitor or ARB. We have second agent. If we look at the force report, we have only ACE inhibitor or ARB. But now, according to 2017 American Academy of Pediatric guidelines, we have second agent like calcium channel blocker, alpha blocker, beta blocker, but we will talk a little bit about beta blocker later on. Combination of alpha and beta, centrally acting agents, potassium sparing diuretics, direct vasodilators. Now, beta blockers are no more recommended because of adverse effects, and more importantly, because of lack of association with improved outcomes compared with other agents, which means that blood pressure, it could lower the blood pressure, but this lowering blood pressure effect is not associated with improved outcome. Now, what, when and how to follow up treated patients? The force report didn't include any recommendation about this issue, the follow-up. The American Academy of Pediatric guidelines, the follow-up depends upon the treatment we have chosen. If we are treating our patients with lifestyle modification, then the patient will be followed up every 3 to 6 months. But if the patient was on medication, then the patient should be followed up every 4 to 6 weeks to 3 to 4 months. And this assessment, periodic assessment of blood pressure, can be either by home blood pressure or ambulatory blood pressure monitoring. Now, we can have an idea about Canadian guidelines, because it is also important to know about this Hypertension Canada 2020. It is very recent, maybe 2 months ago in June. guidelines for prevention, diagnosis, risk assessment, and treatment of hypertension in adults and children. It was published in the Canadian Journal of Cardiology. What are the key messages from the Hypertension Canada's 2020 comprehensive guidelines? First of all, blood pressure should be measured regularly in children 3 years of age or older. The auscultatory method is the gold standard at present. So it is like American guidelines. Second, simplified diagnostic threshold can be used in addition or as an alternative to normative tables. This is a bit different from the American guidelines to diagnose hypertension in children and adolescents because they have set up this simplified diagnostic threshold. And number three, in office, if office blood pressure readings are elevated, then we have to go for ambulatory blood pressure monitoring device, which is recommended using devices independently validated in children and interpreted with appropriate pediatric normative data. So again, here we have to, they recommend to do ambulatory blood pressure monitoring if blood pressure readings are elevated. Now, the fourth message from this Hypertension Canada's 2020, in children with confirmed hypertension, routine echocardiographic evaluation should be performed, routine. This is also different from the American because American echocardiographic should be done when we consider pharmacologic treatment. But here, they said that if children with confirmed hypertension, routine echocardiographic evaluation should be performed and cardiovascular risk factors should be assessed with routine laboratory tests. Health behavior management should aim for a healthy body weight through a comprehensive approach that includes dietary education and increased physical activity. It's almost the same. Secondary hypertension should be ruled out before pharmacological therapy is introduced in children with symptomatic hypertension, target organ damage, comorbidities, persistent, or stage 2 hypertension. This is almost the same as the American guidelines. And initial therapy should be monotherapy with an ACE inhibitor or ARB, not first line in Black children. It seems Black children, they have different approach, or a long-acting calcium channel blocker. The treatment goal is systolic and diastolic office blood pressure and or ambulatory blood pressure monitoring below 95th centile or below 90th centile in children with risk factors or target organ damage. This is different from the American guidelines because American guidelines, all hypertensive patients, our target should be below 90th. But here they make the difference in Canada. If the patient doesn't have risk factors for target organ damage, our target should be below 95th, otherwise should be below 90th. And the last key message was complex cases should be referred to an expert in pediatric hypertension. Now, Mr. Chairman, to take home message, blood pressure should be measured in all children, number one. Number two, hypertension in kids is more common than we think. Blood pressure measurement should be part of routine physical examination of children. Elevated blood pressure must be confirmed on repeated visits, and persistently elevated blood pressures are required. Persistently elevated blood pressure are required for the diagnosis of hypertension and make the appropriate referral. Auscultatory method remain the standard way of blood pressure measurement. Dynamaps used frequently in infant, but if it was elevated, we have to confirm it by auscultatory method. Ambulatory blood pressure monitoring should be considered for the evaluation of hypertension in children. And the last point is the epidemiology of hypertension is a mirror of the prevalence of obesity in any society. Thank you very much.
Thank you very much, Professor Bassam, for this very nice illustrative, demonstrative, practical approach to pediatric hypertension update. I'd like to leave the mic to Professor Fatina Fadel to start her comments before. I have just a couple of comments and I prefer to start with Professor Fatina. Would you please unmute yourself, Dr. Fatina? Yes.
Yes.
Okay,
thank you very much, Professor Bassam. It's a very nice talk and it covers all the aspects of hypertension in children. Actually, we have put guidelines for treatment and diagnosis of in children by our society, our pediatric, our Society of Pediatric Nephrology in Egypt. And when you lecture to that, what we had reached and put in our guidelines, actually, many of the aspects are weeks and even months to get them. So thank you very much for this very nice talk. Thank you.
Thank you very much.
Welcome.
Thank you very much, Professor Fatina Fadel. And I'd like to have the Egyptian guidelines for pediatric nephrology for the issue of hypertension. Please forward it to me. And I'm going to upload it to the within the same presentation of Professor Bassam.
Yes, immediately after this presentation, I'm going to send it.
It is very nice to hear that we have our own guidelines, because always we are lagging behind the others. So this is a very nice point. I like this lecture because it is important and stressed upon two issues I'm believing in, even in adult hypertension. The two issues are the ambulatory blood pressure monitoring. I don't respect any article in hypertension without ambulatory blood pressure monitoring, because the problems in measuring blood pressure in the office. And I think one of the major problems in hypertension and unmet need is to optimize the settings for blood pressure recording and control. So if I want to change my practice and the guidelines, I should depend upon, this is my perspective, ambulatory blood pressure monitoring. I am an echocardiographer. I am trained on echocardiogram since 1994. And I did a lot of echocardiographic examinations. And one of our experience in pediatric came from renal transplant pediatric recipients. More than 70 patients in the Journal of Pediatric Nephrology, Pediatric Transplantation, I think more than 15 years ago. We published the issue of echocardiographic abnormalities in adolescent transplanted kidney transplant recipients. And we found that hypertrophy is more than 40%. And we have a lot of data, univariate and multivariate. The most important three determinants of hypertrophy in pediatric age were the pre-transplant dialysis, anemia, and the post-transplant hypertension. So hypertension is important before and after in clinical nephrology. And I don't like to have long comment, but I would like to ask Professor Bassam about the issue of screening of hypertension in pediatric age. Should we screen all, or we take it as opportunistic when the child is evaluated to measure blood pressure? I would like to hear from you about the school and your preference for screening, Dr. Bassam.
Actually, all kids age 3 years or above must be screened for hypertension, unless if the patient is having one of the, as I said before, conditions that make them high-risk patients, especially prematurity and low birth weight, history of low birth weight and nursery ICU staying, etc., or cardiac patient. If they do have any of these causes, then again here we have to go for screening below the age of 3 years for in all visits to the doctor. But if they do not have any of these high risk, any of these conditions, should be screened after the age of 3 years. You can do it anytime you want, but it is not then evidence-based practice. Evidence-based said that blood pressure should be measured after the age of 3 years, at least once annually. But those who are obese patients or those who have some high risk, not included in the high risk, I mean those who should be monitored their blood pressure before the age of 3 years. Obese patient must be checked at each visit to the doctor. But if you want to take the problem is in my country, for example, pediatricians, they rarely measure blood pressure. they consider that blood pressure is not the business of pediatricians. This is completely wrong. And that is a message I am trying to disseminate everywhere I go, everywhere I talk about blood pressure update in pediatric and adolescents, that blood pressure should be part of our examination, like in adult practitioners. Adult practitioners, they take blood pressure for all patients, almost all patients. But in pediatric, it's rarely taken because in the background, we never give this topic the importance it deserves. So that's why your question is an excellent question. That's why the screening of hypertension in children is obligatory after the age of 3, and sometimes it is obligatory before the age of 3.
I agree with you 100% because I think this is one of our unmet needs to improve, because I think if we early diagnose hypertension, we may reduce the issue of end-stage kidney disease later on, because this may be neglected. And the one of the updates in October in the issue of Pediatric Nephrology Journal, after cardiac surgery, there is a high proportion of hypertension development as a long sequelae. This is why we should depend upon opportunistic and to put in screening. And I'm not sure if there is in the World Day of Hypertension, there is a room for pediatric or is just exclusively adult. I'm not sure from this issue. Do you have World Day Hypertension in pediatric as in adult?
No, we don't. Not to my knowledge. Not to my knowledge. I think we have to make it. Because this is a great idea. I think this is a great idea.
I like.
Yes.
I like I like Lebanon. Why I like Lebanon? Because Society of Nephrology in Lebanon is known as Society of Nephrology and Hypertension.
Yeah.
And I think this is a unique name. I like it because nephrology is dialysis and transplantation by default. But
exactly.
Nephrology and hypertension to stress upon the importance of one of modifiable risk factors. I'd like to stop here to allow my professors and colleagues to have a time for comments and questions. So if we have Professor Riyad, I'd like to start with him. Professor Riyad Saeed, unmute yourself, please. Yes.
مساء الخير.
We hear you, Basha.
Okay. Bassam, it's a very nice, lovely talk about pediatric hypertension.
Thank you.
Okay, and really, I have a couple of comments. I'm glad that you stressed the DEBAR, non-DEBAR, with its quite significant situation, and you stressed also with it the obstructive sleep apnea syndrome that we have, and early morning trouble with hypertension, at least in adults, that we see most of the cardiovascular events that are associated with non-DEBARs occurs early in the morning. So in morning hours. So I'm glad that you really stress this. Secondly, concerning, I remember we have published an article a long time ago about the hypertension Jordanian children. And as you mentioned early in your talks, really, renal parenchymal disorder is quite a common thing, but we have good number of them, renovascular hypertensions, that we have to keep an eye. Very few really endocrine causes, but we have to concentrate about screening, not single reading. And I hope that all pediatricians, when they see patients in their offices, they check blood pressure. Most of the time they will come to us 10, 15 years of age. We do see some pediatric patients. We'll tell them, anyone checked your blood pressure? No, this is the first time it's being checked.
Yes.
It should really be mandatory to check blood pressure in kids, because that's where we start protecting them, protecting future patients from really developing end-stage kidney disease. That's really my comments, but I enjoyed the talk.
Thank you.
Thank you very much, Professor Riyad, for your valuable comments as usual. I enjoy your comments. Do you like to add anything, Professor Bassam?
Yes, I would like to add one important point regarding the screening. You know, there are several studies that have shown that if you detect patients who have elevated blood pressure, I mean their blood pressure between the 90s and 95s, we call them elevated blood pressure. Before we call them pre-hypertension. Those patients, even at this not very high blood pressure, they may have left ventricular hypertrophy. And this left ventricular hypertrophy could be reversible if we start treatment at that time. But if those kids left untreated, they will develop their hypertension to stage 1 and stage 2, and they will be diagnosed during adulthood with cardiovascular event, etc., etc. So screening early on will and should prevent them from lots of cardiovascular disease, mortality and morbidity. It's very important to emphasize.
May I just allow me just,
yes.
What about screening kids of hypertensive parents?
Very nice point, because I remember one of the publications about the even hypertension in pregnancy. This is a very funny article. I like it. When a lady has hypertension during pregnancy, and they observed all the family member later on, even if it is not within this pregnancy, and they found that siblings and daughters of this pregnancy, of this child, infant coming from this pregnancy, are associated with higher hypertension. This means that there is familial trend or environmental factor to be considered. So if we are going to tackle hypertension from the early beginning and to avoid bad consequences, if we have a mother that during pregnancy blood pressure was recorded to be high, we should follow not her only, but all her family, even in the later pregnancy, subsequent pregnancies. So we should improve ourselves in monitoring of hypertension if we want to do a difference.
Okay.
Thank you.
Okay.
Thank you very much.
As I said, if you allow
Yes.
me,
Okay, go ahead.
as I said in one of my slides, that only 15% of hypertensive children are diagnosed. Only 15%. Can you imagine? 15%
imagine,
means
because the data in
Well,
adults,
that's in adults also. We
Yeah,
have trouble
also,
also.
so this is unmet needs that we should work on this in either in adult and pediatric. But I think the problem is more
Even
and more
bigger.
in children. Yeah, bigger, yes.
Yeah.
I agree with this point. Dr. Fatina, do you like to add any point here? From the Egyptian data, what about screening? Do you like you advocate screening or not? I'd like to hear from Professor Fatina. Please unmute yourself. From Dr. Tariq Tantawi, please unmute yourself.
Assalamu alaikum. Very
welcome.
nice presentation, Dr. Bassam, and all best regards for all our colleagues from Arab countries. Very nice presentation, and I would like to have an attention around children from a family with autosomal dominant polycystic kidney diseases. We have to screen them very early, since 3 years, to check for the probability of hypertension. This is part one. Part two, how can our children, especially in the young age, you speak about 1 year, 2 years, 3 years, receive the oral hypotensive drugs? Is the way for some suspension or oily or fluids, or they receive tablets like adult? I want to listen from you.
Yes,
Thank
Dr.
you,
Bassam.
thank you, Dr. Tariq. Dr. Bassam.
most of the antihypertension medications, there is no syrup for it. We have only tablets, but it is not a problem, doctor, because we can crash it and make the calculation and give the proper doses for this. This is not a problem. Even for in neonate, sometimes we can treat hypertension with medications, but this medication should be crushed and dissoluted in a certain amount of water, and then we calculate per each 1 ml of this solution contains how many milligrams, etc., and we apply the proper doses.
Okay, thank you very much.
Even for neonate, I mean, not only 1 year or 2 year.
But it is a real challenge. It is very challenging.
It's a real challenge, yes, yes.
Dr. Fatina?
Some pharmacies actually now are making this preparation. They do crush and they write it on the the bottle itself. And I saw many patients that receive such bottles from the pharmacies and use it much more easier than the patients and
So long as the net is not stable with Dr. Fatina, I think the idea is very brilliant to depend upon clinical pharmacists. And nowadays in Egypt, there is expansion in the number of clinical pharmacists. They are present in everywhere because since 10 years, we have clinical pharmacy faculties, and I think this is a very nice for helping treating hypertension in young by preparing special forms that can help children. I'd like to have the Professor Saeed Khamis, because he is one of the CME members. Dr. Saeed, please unmute yourself. And if I'd like you to start with the questions on chat. If we have questions on the chat, please read them one by one, and then have your comments at the end. Dr. Saeed.
Okay, I will. Okay. There are some. Thank you, Dr. Hussein.
Thank you, Dr. Saeed.
First question, as regard from Dr. May Shawi, as regard target of blood pressure at 5th centile in CKD patient. Is it apply only on ambulatory measurement, or can we apply it on 3 readings of office blood pressure measurement? And second question is, can we combine the use of ACE and it is written carbs, but I think she means ARBs safely. She means ARBS and ACE together. These are the 2 questions of Dr. May. Okay, Dr. Bassam.
I couldn't hear properly the questions, but first question, probably they are asking whether we rely on the auscultatory or ambulatory blood pressure monitoring in order to determine the effectiveness of treatment. This is right?
I think it is, she mentioned as regard the target of blood pressure at 5th centile in CKD patients. Is it
yes.
Apply only on ambulatory measurement, or we can apply, she means maybe we depend on 3 reading of office blood pressure measurement? That's the question.
In fact, according to the guidelines, this should be for CKD patients, this should be on ambulatory blood pressure monitoring. We have to target below the 50th centile of the mean arterial pressure. Mean arterial pressure, we have to, if we look at the ambulatory blood pressure can give it to us. It's not, we don't have to do anything except the program of the ambulatory blood pressure on the laptop will give you immediately all the graphs, all the figures you want. You don't have to calculate it. But if it is not affordable, to us, the ambulatory blood pressure, it is because it is not always available to us. It depends on the facility. If it is not available, then we have to consider those patients like diabetic. Diabetic patients should be below 90th centile. But according to guidelines, it should be on ambulatory blood pressure monitoring. But we cannot say that it is always there. Sometimes it is not there. Then we have to fix below 90th centile as a target for CKD patients, like diabetic patient or other secondary cause.
Excuse me, Dr. Saeed, I would like here to add a comment. Even in adults, I don't like the blood pressure recording in the office. This is why I believe in ambulatory blood pressure monitoring, but because it is not available, widely available, so we can replace it by home blood pressure monitoring, frequent home blood pressure monitoring in adults. And this is what I say to my patients: please record the blood pressure many times during the day and before and night and before sleep, and record it in a paper coming with this 4 readings, serial, many days, and then omitting the first day and taking the average after that. Do you have the same in pediatric, or it is difficult too in pediatric?
No, we can do it, of course. We can do it because also ambulatory blood pressure monitoring is not easily available, except for some centers and some clinic. They do have it because we have to give it to the patient. The patient will take the device with him, unless if the patient was admitted in hospital. So it is not always available, and then we have to rely on auscultatory. But auscultatory, better to make several measurements, not only one single one. But even the guidelines did not insist on the, always there is, if we look at the wording of the guidelines, preferable. It is preferable to look at the ambulatory blood pressure monitoring. They take into consideration the fact that it is not always available to the doctor everywhere in the world. So auscultatory, but auscultatory also requires certain experience, and especially require certain conditions, like especially the patient should be quiet, sitting position, the proper cuff size, and the doctor should be familiar with taking blood pressure in children. Unfortunately, even pediatrician, I would say, at least in my country, I'm not making any generalization, but pediatricians, they are not very familiar with taking blood pressure because they do have, as I said before, some sense that it is not, it's very rarely that children can be hypertensive. But in fact, the prevalence of hypertension, if we combine both pre-hypertension and hypertension, the prevalence is around 6 to 7%. 6 to 7% is not a small percent. So if the patient, if I can see, for example, for each 100 patients, I do have 6 or 7 with hypertension. So it is not a rare disease at all.
If you allow me, Professor Bassam, who I am stressing upon frequent and home blood pressure recording, because if I don't have the ambulatory, the facility for ambulatory blood pressure, repeating measurement of blood pressure during the day and night give me a clue for even masked hypertension, which is quite common in CKD and dialysis in adults. And for auscultatory methods, I think I agree with the Canadian guidelines for adults. 2020 hypertension guidelines is to depend upon automated oscillometric methods, and this is the and calibrated machines, accredited, and that's all. No auscultation, no stethoscope, just the machine, and the machine records blood pressure, and the machine is well calibrated and well known. I think this is the best for adults. I'm not sure about pediatric. Do you?
Yes.
Okay.
If we look at the American guidelines, it was clearly stated that home blood pressure measurement is not accurate, and we should not rely on it because it's not easy even for some doctors to measure blood pressure for pediatric patients. So what about parents? And parents will not use auscultatory; they will use automated blood pressure. So automated will be also different results, and it could be affected by noise, by movement, and so many things. That's why there are several sources of error. That's why we cannot rely. Maybe it is for adult patients, it's a bit easier. It's a bit easier, but for kids, it's not easy at all, and we cannot rely on it. Although it could be correct sometime, but we can't know. We can't know because this doesn't happen in front of us. We don't know the circumstances and the condition, whether all the conditions were respected while taking blood pressure. So we cannot build decisions based on something that we are not sure about. That's why the American guidelines, I think, and I agree with, although the Canadian guidelines, they give some importance of the home blood pressure measurement, but again, it depends on the society. I don't know, in Canada, maybe people are very well educated and probably over there, because this is one factor, of course, we cannot deny this fact. Maybe we can rely on their knowledge and everything. But here, I think, because when the American Academy of Pediatrics issued these guidelines, it is not only for America; it's for the whole world. So even if it was done at home, we should take it with caution. But building decision based on it, I think it's not very good decision.
Okay.
What about combination ACE plus ARBs?
Combination between, sorry?
Plus angiotensin II inhibitor and angiotensin receptor blocker.
I can't hear properly. I'm sorry. Very sorry.
ARBs and
Combination,
ACE.
combination.
Combination, ACE and ARBs.
Yes,
Yeah.
yes.
This a little bit risky, although sometimes we can do it. This is a little bit risky because if you, especially for CKD patient, because the serum creatinine could be raised significantly. If the serum creatinine increased by less than 0.3 milligram, then it is acceptable. But sometimes if you make the combination, the serum creatinine may increase more than this, and this may, we may find ourselves a little bit confused whether this increase of serum creatinine is related to our medication or the disease itself. So it may be, it may require certain vigilance before we apply this combination. Otherwise, ACE alone or ARB alone could be a better choice.
Yeah. Complementary to this question, she asked again, what about ACE and ARBs as a first line medication in non-proteinuric and non-CKD patients?
It is a first option.
Yeah.
It is a first option for all patients, not only for CKD patients and the renal problem. But second option can be, but of course, this is the first option. I mean, ACE inhibitor and ARBs first option for everyone, including especially CKD patients and patients with renal abnormalities. But even for other patients who have no renal problem, this is also first option according to American guidelines. Second option, then we can go for calcium channel blockers and etc. And alpha blockers and beta blockers.
Last question from Dr. Shukri Amara from Saudi Arabia. Do we still have a role of centrally active medication like clonidine or methyl dopa in resistant hypertension? You heard me, sir?
Yeah. In some selected cases, yes. In some selected cases, but it is not recommended as a first or second or third option. But for some selected cases, of course, if the patient we are taking care of is having life-threatening condition or very resistant to hypertension to treat, etc., then everything is allowed, I think. And nothing will prevent us from utilizing any antihypertension agent, including centrally acting.
Okay.
Even in adult, Dr. Saeed, adult hypertension management, centrally acting are out of favor nowadays. Yeah. Especially if I consider chronic kidney disease, they are not there in chronic kidney disease and not in dialysis. So I think their use is limited significantly. But if I have a patient who is old, senior and very old, and is controlled on one of them, I don't play with the antihypertensive medication so long as hypertension is controlled. But I didn't start or initiate any patients on centrally acting antihypertensive drugs.
Yeah. My question, if you allow me, Professor Hussein.
Yes, yes, please.
Yeah, Professor Bassam, first of all, thanks for your elegant presentation.
Thank you.
Second, my question regarding the hypertensive crisis, or what's meant by the urgent and emergent hypertension. Is it different for in children compared to the adult in prevalence and management? Thank you.
Is it what? Sorry, because the voice is
different.
I mean
hypertensive emergencies and urgencies in pediatric age. Is it different in the approach than adults or the same lines?
I can't, because I don't have in my hand a comparative study between the urgency to compare between adulthood and childhood. I have no idea exactly. I don't know how to answer your question because I have no idea. I never went through something similar to what you are asking to compare between. But I think there should be no problem. There should be no difference in headlines. But in details, of course, we have to always consider the cause of hypertension. In pediatric patients, you know, the main difference is that most of our patients, they do have some other causes. Yeah. I mean the hypertension by itself is a marker of other disease. I mean,
Professor
what I
Bassam,
want, sorry,
okay.
what I wanted to say that hypertension in children is a marker of other disease. So this other disease should be treated, and this treatment of the other disease, I mean secondary hypertension, this treatment takes priority. Okay, in addition to antihypertension medications. So when we are talking about pediatric hypertension, we are talking about treatment of so many different diseases, not only hypertension. And this is not the case when it comes about adult hypertension, because in adult hypertension we are mostly talking about essential hypertension. This is the point.
The question by other way, Dr. Bassam, because I think the question, Professor Saeed, about urgent and emergent hypertension, I'd like to ask you, do you use intravenous antihypertensive in pediatric?
Of course, we use hydralazine very frequently. Hydralazine, we are using, this is potent vasodilator. In most of ICUs, the first line treatment in ICU patients is hydralazine. So we are using hydralazine, of course. And of course, we can use other medication, especially calcium channel blocker and ACE inhibitor and ARBs.
Okay, thank you very much. Professor Faisal Shaheen. Thank you, Dr. Saeed. Professor Faisal Shaheen. Yes, you are
thank
welcome.
you very much.
Thank you.
Thank you.
You are welcome.
Saeed, as usual, excellent talk and very, very detailed. And I wonder, actually, there are many similarities between the adult and pediatric. And there are specific things for pediatric, but still we are in the same line, either adult or pediatric, treating hypertension in both all the ages. But still, you know, the relationship between congenital abnormalities and hypertension in children, which is more prevalence in children, is it more common than other things like, let us say, glomerulonephritis in adult, or it is almost the same? Because I had a very big study long time back, maybe almost 15 years back, about children with abnormalities, and we found that the hypertension was more prevalence in children with congenital abnormalities if they have. And this is one of the things. The second is excellent talk, clear and to the point. Thank you very much.
Thank you very much, Professor Faisal. Yes.
Yes.
Okay, Dr.
You are most welcome. Yes. You are most welcome, Faisal. الحقيقة, in fact, hypertension in children, we have to differentiate between age groups. If we talk about neonate, is different from infant and small children. Small children are so much different from big children, and big children are different from adolescents. So mainly we have four age groups: neonate, small children, big children, and adolescents. But in the children below 6 years, the congenital anomaly of kidney and urinary tract plays a major role in pediatric hypertension. So of course, yes. Of course, the answer is yes, because the blood pressure is a common finding for patients with congenital anomaly of kidney and urinary tract. But this hypertension become less important with age, because here, if you go to children who are older than 6 years, from 6 to 13 years, here the renoparenchymal disease is most important than congenital anomaly of urinary tract, of kidney and urinary tract. But especially for children who are younger than 6 years of age, yes, it is a common problem. It's not essential hypertension. It is secondary hypertension to malformations of urinary tract and kidneys.
Okay. Thank you very much.
Thank you, Dr. Faisal, very much. Thank you. I think the issue of hypertension is very broad, and I like your sector of presentation about searching for etiology and thinking of electrolyte disturbance, hypo or hyperkalemia, acidosis or alkalosis. All these may be clue for certain etiology that necessitates certain medication. For example, if we diagnose Liddle syndrome, we are going to give amyloid or trimetrin. If it is secondary aldosteronism or apparent mineralocorticoid excess, we give spironolactone. So according to the cause, we can even manipulate antihypertensive. I'd like, because we have now 2 hours and 20 minutes, I'd like to leave the mic to Professor Fatina, but just for one comment and then to close the session. Dr. Fatina.
Thank you very much for Professor Bassam for this information about hypertension in children. Actually, he gathered all the information that could be given for this title. He covered every part of hypertension in childhood. Maybe hypertensive emergency, actually we see many patients and receive many patients with urgency and emergencies of heart. And yes, we deal with them mostly intravenous medications until we control hypertension and past the emergency situation. Thank you very much, Professor Bassam.
Okay, thank you very much, Professor Fatina, for your presence with us all through this time. Thank you very much, Professor Fatina. I would like to conclude that we enjoyed the presentation. It's very clear, practical, applied, updated. Thank you, Professor Bassam Saeed, for this very nice night about hypertension update in pediatric patients. And this is just a symbol of appreciation from the Egyptian Society of Prof and Transplantation Continuous Medical Education for Professor Bassam Saeed in recognition of his distinguished contribution in delivering this session update in pediatric hypertension. Really fantastic talk. And also I'd like to appreciate and the presence of Professor Fatina Fadel and her valuable comments in this session too. I think this is the last slide of this presentation. I'd like to allow Professor Bassam Saeed to conclude the session and to close it. The last assessment is to Professor Bassam.
Thank you very much. I am honored and pleased, very pleased by this very nice certificate of appreciation. This is my honor and my pleasure. It's always an honor for me to be present with you, talking with you, and discussing and trying to provide some details about the hot topics. I think hypertension is a good topic, excellent selection, because hypertension, I think it needs a conference, not only one session. Thank you very much for hosting me, and I'm always glad to be part of your wonderful group. Thank you very much.
Thank you very much, and we hope that we'll find time for serial presentation, because we love and like your style, either in live or in presentations. Thank you very much, Professor Bassam. Thanks so much, Professor Fatina. And tomorrow or on Tuesday, I'm going to upload the video to the YouTube, because I changed my style by putting categorization, definitions, and so there is some change in the academy. So Tuesday, you'll find the video uploaded to YouTube. Thank you, goodbye. And I'd like to thank all the attendees from by professors and colleagues from the Arab world and from the UK and other countries. Thank you and goodbye. Goodbye.
Goodbye. Goodbye.